Okay, we're ready to go. All right, you guys, we're going to welcome Jennifer and let her take it away.
Well, thank you very much for the invitation to speak with you all today and for the nice introduction. It's really a great organization, and we have, in my work at UPMC, we have referred numerous people diagnosed with cancer and their families to your organization. So you guys are doing great work, and I really like this series that you're doing, and we'll definitely tell people that I work with about it.
Perfect.
Today I'm going to talk a little bit about sleep, and particularly sleep in those who have a diagnosis of cancer and also their intimate partners. The first slide here. Next slide, please.
Okay.
Poor sleep quality in the general population has been reported to range between 29 to 32%. And sleep problems in the general population have been associated with depression and poor quality of life. And more recently, research has shown that poor sleep is also related to metabolic abnormality, cardiovascular disease, and even increased risk of mortality. Some of the biological mechanisms explaining this link may be related to different cytokines that are related to inflammation, and also something called C-reactive protein. I won't go too scientific on you, but if you want more information about that, just let me know. The next slide. Sleep problems in the context of cancer is actually much greater. About 45 to 80% of people report poor sleep quality. And in people that are diagnosed with cancer, this is often associated with increased problems with depression, poor quality of life, and actually more severe symptoms like pain and fatigue. The sleep problems also often persist beyond the treatment phase and can go on for many years. And again, some of the underlying biological mechanisms we think are associated with sleep and kind of disease progression is things like natural killer cells and inflammation have been looked at, both by our team and other researchers. And we've found that people who sleep less than 6 hours or greater than 10 hours a night actually have greater risk of their disease progressing. And so sleep is very, very important, not only for your mental health, but for your physical health. Next slide. About 61% of adults also sleep with another person, and research has shown that anywhere from 25 to 33% of relationships are adversely affected by these sleep problems. And if any of you had where one partner is more stressed and had difficulty sleeping or problems with snoring or another sleep disorder, you may be aware how difficult it is for the other person to sleep. There's also been research on people who provide care, or the intimate spouses or partners of people diagnosed with cancer, and they tend to have higher rates of insomnia, longer sleep latency. And what I mean by sleep latency is the time it takes to get to sleep. And so oftentimes it takes them longer to get to sleep. They're awakened more often or have more sleep fragmentation, and also in general just sleep a shorter period of time over the course of the night. Next slide. There's been some research, although very little, about kind of sleep between partners. And they have found that as illness becomes more severe or prolonged, the sleep between somebody with diagnosis of cancer and their partner tends to become more synchronized or more similar. So if your sleep is good, your partner's sleep will probably also be good, but if it's poor, that would affect your partner as well. So this one study that's been done has shown that people with cancer actually usually have more frequent awakenings in their partner, use medications for sleep more often, and have lower levels of sleep efficiency. And what that means is that it's the amount of time that you are asleep over the divided by the time that you're in bed. So somebody that has poor sleep efficiency, it would mean that they have greater or less than 85% of their time asleep when taking into account the time in bed. So hopefully that makes sense. And they've also found that the sleep, rest, and wake activity parameters are highly correlated between people sleeping together, those diagnosed with cancer and their partners. But in general, both the people with the diagnosis of cancer and also the caregivers usually sleep less than 7 hours, which is much below what's normally recommended, and also have approximately 18 awakenings lasting 3 to 4 minutes a night. So this would be considered poor sleep quality. Next slide. And when researchers have studied just caregivers or those intimate partners of those diagnosed with cancer, they found that caregivers on average report sleeping about 6 hours a night, but actually when actigraphy is used, which is a way to monitor your sleep more objectively, is kind of the gold standard of measuring sleep along with that people only slept about 4.8 hours a night, and these were the spousal caregivers. They also found that chronic sleep loss was associated with higher levels of stress, and as you can imagine, also more marital discord. And next slide. And this pertains mostly to people caring for partners of those with cancer, but they have shown that caregivers have an increased risk of cardiovascular disease, including coronary heart disease, stroke, and at this time we don't really understand the mechanisms, but one possibility is that sleep may be, the lack of sleep or poor sleep might be predictive of people developing more cardiovascular disease. And so this is under study right now, both in caregivers, but also in the general population. Next slide. And so today I thought I'd talk just a little bit about different sleep problems and just give a general overview of kind of the treatments that are recommended. I'll talk a little bit about insomnia. This is probably the most common type of sleep disorder people experience. Sometimes it's substance-induced sleep disorder, which could be actually a result of chemotherapy and possibly the side effect of menopause causing sleep problems. Also, sleep apnea is common in probably about 10% of the population. And there's two types, central and obstructive. And then also restless leg syndrome. And then I'll talk just briefly about circadian rhythm sleep disorders and parasamias. Next slide. So the first and probably most common sleep disorder is insomnia. And this is generally defined as unhappiness with your quantity or quality of sleep. And this can include trouble getting to sleep, staying asleep, or waking up early. There has been some research that has suggested that those who wake up early actually they may be more likely to have also depression associated with their sleep disorder. The sleep disturbance often causes distress or impairment in functioning with either your work life or personal life, or even make you more emotionally vulnerable. These sleep problems have to occur for at least 3 times a week and be present for about 3 months to receive a diagnosis of insomnia. And the sleep problems have to occur despite ample opportunity to sleep. So if, for instance, you have a baby or crying baby, or you don't have enough time to sleep, that this wouldn't necessarily be considered insomnia. It's when you actually have ample time to sleep. And insomnia is also diagnosed if you can't explain it by any other physical, mental, or sleep-wake disorders. And also, it wouldn't be attributed to substance use or medication. Next slide. So usually people who work with insomnia usually try behavioral strategies first, and these include just actually pretty basic things that you probably are all aware of, but kind of limiting use of caffeine and alcohol and tobacco, usually at least 4 hours before bedtime. Exercising regularly is very important for sleeping well, and also avoiding large meals before bedtime. And then it's really important that your sleep environment is conducive to sleep, so decreasing noise and light, making it a comfortable temperature, those kinds of things are important to make it an environment that is conducive to sleep. Next slide. It's also important to kind of wind down, decrease activity and stimulation about 30 to 60 minutes before bed. Actually taking a hot bath 2 hours before bed actually increases your temperature. And this actually naturally usually occurs even without a bath in most people who do sleep well. But if you're someone that doesn't sleep well, kind of forcing your body to have that temperature spike about 2 hours before bedtime kind of creates prepares your body for sleep. Also, many people now use electronics, either TVs or tablets or even cell phones in bed. And this actually can stop the production of melatonin, which is actually important to induce sleep. And so kind of unplugging from electronics 30 to 60 minutes before bed is really important. And then also, if you have the opportunity to have natural light in the morning, that's also helps you kind of wake up and actually helps regulate that sleep-wake cycle. Next slide. We also use something called stimulus control in addition, and these are things like keeping a fixed wake and bedtime. So the more consistent you can wake up and go to bed at the same time every night, even on weekends, the better your sleep will be. Also avoiding naps, and I know that's really hard, especially when you're going through treatment, and I have a hard time recommending that because people are sometimes very, very tired. And so, but avoiding naps kind of consolidates your sleep into 7 or 8 hours rather than if you get 2 hours or even an hour of sleep with a nap, it might be harder to get to sleep at night or get a full 7 or 8 hours then. Also limiting your bed to only sleep and sex, so try not to work in bed or do any other activities will help you sleep better. And then one thing we recommend, again, which I think can be hard to do, but if you can't get to sleep, to get up after about 20 minutes and go do something really boring. And this could be like reading a telephone book or something that's not stimulating, like don't read a book that you enjoy or watch an action show on TV. Do something that would kind of be boring and put you to sleep. And then the last thing is sleep restriction, and I kind of use this as a last resort, but this is actually kind of reducing the amount of time that you can sleep, like down to 6 hours or so, trying to consolidate your sleep even more. And again, this is really hard when you are kind of struggling with cancer and the treatments associated with it. So I don't like to use this except in rare circumstances, but it does, if you can consolidate the sleep and kind of restrict sleep to like 6 hours, rather than if you're taking naps and kind of in bed for long periods of time without sleeping, this can be a beneficial strategy. Next slide. We also use something called cognitive behavioral therapy for insomnia. And this is very similar to cognitive behavioral therapy in general. But here we not only use the sleep hygiene and stimulus control, but we also kind of look for maladaptive thoughts and patterns of these thoughts that may actually be contributing to your sleep problems. And so sometimes people can be kind of catastrophizing something going on in their life, or possibly kind of perseverating on thoughts and kind of learning what those patterns of thoughts are and kind of challenging them and finding out maybe if they're related to some core beliefs that you may have can be an effective way to also kind of be able to improve your sleep. And then we also teach people relaxation techniques, and this can be in the form of breathing or progressive muscle relaxation or meditation. And these things can all help kind of facilitate sleep. Next slide. Now I'll talk briefly about substance-induced insomnia. Next slide. And this is insomnia, so the same symptoms, but these are caused by medications oftentimes. And so with the internet being readily available, it's easy to look at kind of side effects of medications, and then also have your pharmacist or your physician kind of review your medications to see if any of them might be actually causing sleep problems. And sometimes you can either just change the timing of the medication. Sometimes if you're taking the medication at night, sometimes that may be interfering with your sleep. And so you can just change the timing of the medication, or sometimes they can come up with an alternative medication that may still help you physically, but may not have the same side effect profile. Next slide. And some of these are also include things like drugs and alcohol and tobacco, which can also interfere with your sleep. Most people think in particular alcohol and marijuana can actually help you get to sleep, but it actually disrupts your the stages of sleep and REM sleep. And so even though it may initiate sleep, you're actually getting worse sleep at night when you use drugs or alcohol to kind of initiate sleep. Next slide. Also things like surgeries or extended time in the hospital. I've seen that really disrupt people's sleep. And even chemotherapy, when you develop a lot of fatigue, you might sleep more and then have more trouble sleeping at night. And then just the stress of with the diagnosis and interference with occupational and social functioning that your diagnosis might cause can increase your just overall stress and lead to difficulties in sleeping. I often in the hospital, these here, I work mostly in Montefiore and Presbyterian, and here, and I think it happens at Shadyside as well, but oftentimes people come into the hospital like once an hour to either take your temperature or check on you and wake you up. And I know this disruption in sleep while you're in the hospital can really interfere with your sleep even after you go home. And so at least the staff that I work with, if you ever are in the hospital for an extended period of time, I ask them to kind of put a sign on the door if you're medically stable and give yourself like 4 to 6 hours of sleep without interruptions, if that's, again, medically appropriate. So don't hesitate to ask for that if you're in the hospital for any extended amount of time. At least the staff that I've worked with have been very willing to do that to help you, so you don't get sleep deprived while you're in the hospital. Another common sleep disorder is sleep apnea, and this has to actually be diagnosed at a sleep disorder center. They're able to do it at home now. It used to be that you had to come in, and this is kind of where people stop breathing at night, and some of the symptoms that you might recognize are snoring. Just because you snore doesn't mean you have sleep apnea, but if somebody noticed that you're gasping or having pauses in your breathing while you sleep, this might be a indication. Also, people who have really a hard time staying awake during the day, this may also be indicative of somebody with sleep apnea. And there's different ways of diagnosing it. And again, this is usually done at a sleep disorder center or at a kind of they take a mobile unit to your home to kind of evaluate you. And there's both, next slide. And next slide, and so there's both central sleep apnea, which is more of a neurological disorder, and then also obstructive sleep apnea, which is more common. And the obstructive sleep apnea is usually where you have excess kind of skin in your throat area and causes this difficulties with breathing. And so surgery, actually the first line of treatment is weight loss. And that sometimes does significantly help somebody with sleep apnea. And that's maybe all the treatment that they need. Also reducing substances before bedtime can also reduce the possibility of sleep apnea or decrease the severity. And then probably the most common treatment is the use of BiPAP or CPAP. And this, as you can see in the picture here, is an example. They've gotten a little bit nicer looking and more comfortable over the years. But this is really important. It keeps your airway open. It's kind of a high pressure air that keeps your airway open so you don't breathe. And it is really important to treat sleep apnea because it is associated with increased risk of depression and actually mortality. So it's something not to go or leave untreated. There's also dental devices now that are available that some people can use that also helps with the breathing. And then, of course, surgery, which is kind of a last resort, but also effective. Next slide. Restless legs, this is also has about the same rate of prevalence as the sleep apnea, but sometimes side effects from medications can cause this. It's usually like a tingling in the legs, a feeling of kind of wanting to move them to kind of reduce the discomfort. It's usually not painful, but it's just uncomfortable, as people describe it to me, and moving them actually helps reduce that sensation that they experience. Sometimes people describe it as pins and needles, kind of on their in their legs, and sometimes it keeps their partner awake because they move. And so, kind of reviewing the side effects of medication, lifestyle factors that might be contributing, and then looking into some treatments like magnesium or iron supplements. And then there's some other medications that are also sometimes used to treat restless legs, but this should probably be diagnosed and treated at a sleep disorder center with somebody that has expertise in this area. Next slide. The circadian rhythm sleep-wake disorders are also probably a little bit more rare. I mean, jet lag is probably more common for those who travel. Sorry, I'm getting a call. I apologize. Shift work can also cause these sleep-wake disorders. For those who work at night, they may have more trouble sleeping and particularly if they do this for many years, may actually have trouble actually returning to a normal daytime sleep pattern. There's also a non-24-hour sleep-wake disorder. This is mostly more common in people who have vision impairments, and then just irregular sleep-wake rhythm disorders. Next slide. And again, if you thought you had any of these or you knew anybody that might have these, I would definitely have them evaluated at a sleep disorder center. And there's several different treatments. Probably the most common is bright light therapy, and sometimes this is actually used for depression as well. And so, and insurance companies sometimes will cover this as well. If you do have kind of problems with sleep and/or depression, these bright light therapies, like you see in that picture, can be used. And again, natural light is really important for waking up and keeping your sleep-wake patterns regular. Also sleep medication, of course, particularly for jet lag and things like that. But again, we don't recommend it long-term. It should just be temporary. Many of the sleep medications have side effects and also can be addictive depending on the sleep medication. And then there's also chronotherapy, which is kind of if somebody's going to bed at like, say, 5 o'clock in the morning and then sleeping until 2 o'clock and they have a desire to kind of sleep a normal when most people sleep, say, going to bed at 10 at night and waking up at 6 in the morning, then we kind of move their sleep around all the way 1 hour at a time, and it can take a couple weeks to do this until they kind of are sleeping at the time that they desire. And that's called chronotherapy, and again, should probably be guided by somebody that has expertise in sleep disorders. Next slide. And these are parasamias, and I won't go into great detail about these. Some of them are very interesting, but they tend to be pretty rare. Kind of in the 20 years I've been here at UPMC, I've maybe seen probably less than 10 people with these parasamias. And so it's not terribly common, but they can cause, particularly the sleep terrors or night terrors, can cause actually physical harm to their bed partner. And some of the medications, sleep medications, have caused sleepwalking or these confusional arousals. So medications can also contribute to some of these parasamias. Next slide. And in general, again, these are rare and difficult to diagnose sometimes. And so they should probably be evaluated by an expert in a sleep disorder center or and treated by somebody that has expertise in that area. Next slide. So I'm just briefly going to talk a little bit about some of the research that we have done in the area of sleep, both with people diagnosed with cancer, but also their family members. Next slide. I primarily work in the liver cancer center, so most of my clinical work is done there. As far as our research, we do include people from all over Western Pennsylvania. They're often included in our research protocols and things like that from many of the community cancer centers across Western Pennsylvania. But generally, I do have worked a lot with people that have a hepatobiliary or pancreatic system-related cancers, and these are some of the diagnoses I work with. Next slide. And so the first kind of study that I'll talk a little bit about is this is some of the socio-demographic characteristics of the people that were in the study. This is a study that included about 292 patients. The mean age was 62 years. Most were male, about 63.7%, and most were Caucasian, about 91%. You can see the diagnoses here. The majority also included like hepatocellular cholangiocarcinoma, or otherwise known as like liver cancer, primary liver cancer. Next slide. And you can see here that the mean sleep duration was about 6.5 hours. So again, they're not getting the recommended amount of sleep, which should be about 7 or 8 hours. It also took about 30 minutes for people to get to sleep, and their sleep efficiency was poor. It should be around 85%, and here you can see it's 79.9%. And this is the time, again, the time that you are sleeping versus the time that you're in bed. So you want to be 85% of the time in bed, you should be sleeping, or that's what's recommended. And then poor overall sleep is associated with a 5 or greater score on this particular questionnaire. And so most patients had a 7.6, which again is very poor sleep quality. Next slide. And so Wendy mentioned that I was interested in psychoneuroimmunology, and so I'm very interested in kind of understanding the biological mechanisms that kind of link these psychosocial factors and things like sleep with the cancer and tumor growth and development and metastases. And so we study kind of different parameters of sleep, and I'll kind of just briefly describe what this is, the findings here. This is basically saying that those who had shorter sleep, it's associated with one of the kind of master regulators of different cytokines or biomarkers of inflammation. And so here, in conclusion, the shorter you sleep, the less likely you're going to have higher levels of this interleukin-2, which is associated with kind of controlling other cytokines. And next slide. And again, here, sleep duration is associated with something called interleukin-1 beta, which is also a biomarker of inflammation. And next slide. And also tumor necrosis factor. You can see here sleep duration not only at the time that it was measured, but also predicts kind of future elevations in tumor necrosis factor. So the less you sleep, the more likely you're going to have inflammation in general. And then similarly, another biomarker is interleukin-1 alpha. And again, sleep duration here is associated with increased inflammation. So the shorter you sleep or the less sleep you get, the more inflammation you have. And these biomarkers are associated with the cancer and possibly growth of cancer. And we've also, next slide. We've also looked at the family caregivers or intimate partners of those who are diagnosed with cancer. Next slide, please. And next slide. And here, just briefly, we've talked, here we have, you can see most of the people diagnosed with cancer are male, where most of the spouses or family caregivers are female. Mean age is about 62 for those with cancer and 55 for those partners of the people with cancer. And again, majority are Caucasian and also married. Next slide. And again, the diagnoses are similar to the last study, and in general, I work with mostly primary liver cancer, but we also see some people that have had their cancer metastasized to the liver, and then we see treatment, both surgical patients, but also those that are treated with a chemotherapy or 90 yttrium, which is a type of radiation that's actually injected into the liver. And so you can see the majority actually received regional chemotherapy or this radiation treatment, and then about 24% underwent surgery or radiofrequency ablation. Next slide. And you can see here sleep duration. This is with kind of pairs of patients and their partner, and patients slept actually a little bit longer than their partner at 6.47 hours versus 6 hours. It took about 22 minutes for patients to get to sleep and 24 minutes for their partners to get to sleep. And here the sleep efficiency was a little bit better, and when they had a bed partner, for both the person with cancer and also their partner. And then here we're just looking at next slide. And here we're just kind of looking at the relationship. We were wondering who might be disturbing who, whether the person that has the cancer was kind of maybe waking up their partner, or whether their partner was waking up the person that had the diagnosis of cancer. And so here we actually see kind of a bidirectional relationship where you're kind of waking up each other potentially. And next slide. And also, we didn't see a lot of relationship between the time it takes to get to sleep between the person, like between the two partners. And only in one situation did it seem like the person that has a diagnosis of cancer seemed to take longer to get to sleep, and that might have affected their partner's ability to get to sleep. But again, we didn't see a huge correlation or relationship here. And then in the partners, so this is the family caregiver, the spousal caregiver, we found that those people who slept less than 6 hours a night actually had a higher level of C-reactive protein, which is a biomarker of inflammation that can be associated with cardiovascular disease. And then next slide. And we found that not only sleep was associated with elevations in C-reactive protein, but also the heavier you are weight-wise, as well as depressive symptoms were associated with increased elevations in C-reactive protein. Next slide. And next slide. So in general, those people that engaged in our study and the study was not about sleep. It actually was about another topic, and so we measured sleep as part of that, but actually it wasn't the goal of the study. But in general, we found that both those diagnosed with cancer and their partners had a pretty poor sleep quality, had a short sleep duration, and this was highly correlated with biomarkers of inflammation. And there was some relationship between both the person diagnosed with cancer and their partner in regards to problems with sleep. And next slide. So some of the things that we're planning to do is kind of understand sleeping patterns of people diagnosed with cancer and their partners in greater depth, kind of using the gold standard of measuring sleep, which would be in a sleep laboratory. And I think it might be very hard to get people there to do that, because I think everybody's time is very valuable, and they'd probably rather spend it with family and friends rather than in a sleep disorder center. So we may do this in a home environment to make it a little bit easier. Also, kind of once we understand kind of more what the sleep problems are, and kind of understanding what predicts what sleep problem, we're in the process of developing a dyadic sleep intervention. Most interventions are kind of targeted at one person, but we're working with a collaborator in Miami to kind of develop a intervention that's both for both partners rather than just one, because it's usually not only one person has the sleep problem, it usually affects the other person. So that would be our goal there. And next slide. And I have many, many collaborators and students that help, and most of all, we really appreciate all the people that have participated in our studies and filled out our long questionnaires or allowed us to take their blood to kind of better understand sleep problems and other things that we study, and without their participation, we would have a less understanding, I think, of these sleep problems and also other things. And my goal is also to develop interventions, so not just to study it, but to actually understand it, so we can develop effective interventions that are evidence-based and kind of, in the end, would help people, in this case, sleep better. And next slide. And I just wanted to thank you all again for your time. And if you have any questions, I'm happy to take them now, or feel free to email me.
So we're gonna open the discussion up here to everybody, either via the chat box on the right. If you type into the chat box questions for Dr. Steele, or you can raise your hand. I'm sure you all have some questions. Thank you so much for the information, was just amazing and very interesting to me, because it is one area that I do address with my patients. Oh, I'm sorry, my dog is barking. I address with my patients, and I think it's interesting it's affecting the family too, which is so true, because we work with caregivers, right? And that is so important to know, because I have so many caregivers that end up getting cancer, while they're taking care of their loved one. And I kind of wonder if their immune system is, kind of compromised at that point. So any questions? I see something here. I see one in the chat box that says, on an early slide, it cited J-shaped and U-shaped sleep. What does that mean?
Oh, good question. That was on one of the earlier slides, and also on another slide. So that suggests that people who have a short sleep, like 6 hours or less, or 10 hours or more, tend to have more disease progression or increased risk of mortality. And so it's usually both short sleep and long sleep that are associated with that. And it may be that the long sleep might be associated with more what we might call morbidity, like more comorbid medical problems, and they may be sleeping longer due to fatigue and other issues. And so that's, we think, why that's more than 10 hours is related to increased mortality. And then the sleep deprivation on the other side, less than 6 hours, makes more sense. It's more associated with inflammation and